So if you can't hear me throughout this, just wave your hand. I'm not going to use a mic. I'll just kind of yell. You can't hear me? Okay.
You're going to have to yell.
Okay, I will yell, because we couldn't get the mic set up. But this is on biologics, but specifically monoclonal antibodies. So biologics is a really big term. And like we were just talking about, there's also the subcategory of like bioidentical hormones, which some of you might be interested in, and that's what the email is going around. If you want, I did also do a presentation on that in another rotation, so I can send information on that. But this one we're focusing on the monoclonal antibodies because they're the newest, they're the weirdest, and the hardest to pronounce. So hopefully by the end of this you won't be as afraid about those long names. Alright, move on. So what are biologics? Like I said, they're a really broad category. But really these encompass anything that is derived from a living organism. So this includes your monoclonal antibodies, and then also insulin products, blood products, and vaccines. So things that we use on a regular basis we see, they're not this weird kind of brand new thing. You know, they've been around for a long time. However, the monoclonal antibodies are pretty new, and they're just a subset of biologics. So any questions on that before we move in further? Okay. Maybe. Okay, so what are these monoclonal antibodies? Also called MABs, you might hear them say, because they all end in that MAB, which is the MAB. They're just antibodies that are directed towards a specific cell surface protein. So just think of them as this great immune defense that is targeted right to one thing, you know. And then they're really specific, and which helps improve selectivity. And then they also alter disease course by several different autoimmune disease disorders. And this category is growing, as you'll see through this presentation. So originally, a lot of times, when you think of monoclonal antibodies, you think of like cancer, chemo medications. That's kind of where they started. You know, and as when we go through this, you'll see that's where a lot of them are categorized. However, this is branching out into very specific things, including as far as hyperlipidemia for treatment. And we'll go into that at the end, which is pretty cool. So this is a very general scheme of how they're made. So you start with a host. Sometimes it's a mouse, sometimes it's a hamster, sometimes it's in a petri dish. It just depends, and that will make more sense when we get into the naming. But they give it a specific antigen, they inject it to this mouse, or whatever the host is, which creates the antibodies. Then they combine it with a tumor cell, which helps proliferate the antibody, so we get a lot more of it. And then it tags it along with whatever specific cell we're trying to target. And then you get the cloning of that, so we get a whole bunch more of these little antibodies. And then we have our monoclonal antibody that is specifically formulated for this antigen up here in the beginning. So, any questions on that? Okay. So really just kind of ignore the specific details here, but really just think one antigen that's injected and multiplied so we can get a bunch of antibodies that are specific for it.
It helps make sense though. I've
Yeah.
heard it explained that way before.
Yeah, so just kind of really specific, like, matching. Yes?
Can these monoclonal antibodies be tagged with radiation to bring radiation to that tumor?
Yes. They are often used in combination along with like many chemotherapy agents, but there's not like a specific pairing that I know of. That's a little bit beyond my knowledge. But they are used with radiation. Is that the question?
My question is whether they can be tagged with radionuclide.
Oh, okay.
So that since they are going into the tumor, that in addition to the biological thing in the tumor, that they also deliver radiation to the tumor.
I see what you're saying. So the question is, can they be tagged with like a radionuclide to deliver radiation to the tumor specifically and not just throughout the body? At this point, as far as I know, that isn't developed, but I wouldn't say it's not in the process. these are growing, I mean, every day I'll get an email saying there's a new one or a new combination. So as far as I know, that's not been developed yet, but it may be or it might be on the way. So this table is going to help kind of break down the naming. And I apologize if it's a little small. I was trying to squeeze everything into it at once. But I'm going to spend a lot of time on this because once this makes sense, the rest of them make a whole lot more sense. So they're broken down into two components. So you have this side over here, which is on the target, and then the source. So if it was that mouse or where it came from. So we'll start with the target. So if you see a CI in the name, so like here in Bevacizumab, it means it's targeting the circulatory system. So what you'll see here later, the Bevacizumab is a VEGF inhibitor, so it inhibits angiogenesis, so the blood growth into the circulatory system. So you can kind of start thinking of them that way. And even if you have no clue what this Bevacizumab is for or what it's treating, you can kind of think, oh, that must be something to do with the blood supply. And then you have LI, which is targeting the immune system. And then OS for bone, so like Denosumab or Prolia, you might have heard of. And then TU, which is tumor. So there's a lot of these, there's specific guidelines that are published, so every new one that comes out has to follow these guidelines for naming, so that we can understand what they're for and then how they were derived. So these are the most common ones that you'll see, but like I said, if you look this up, there's a whole list of different targets that are for these agents. And then the source is going to help a lot with monitoring side effects, which is really cool. So you have the mouse, which is just O, and these are 0% human. So can anyone guess why we care how much percent human it is?
Reactions.
Exactly. So the further we get from being humanized, the more of a foreign body it is, and the more chance of getting an allergic reaction or an immune response there is to these agents. So when there's, in this rule, it isn't 100%, as you'll see. Sometimes when you get into these like chimeric and humanized, there's sometimes more with the humanized and chimeric as far as allergic reactions. But in general, you can kind of look at it as the closer we are to being more like you, the less you're going to react to it. So you have O for mouse, this XI, which is chimeric, which means it's about 34% humanized. And then the ZU, which is humanized, which is a 90 to 95% humanized. And then U, which is just human, 100%. And so that's ideally our least reactive one. So any questions on these? It's a lot to take in.
Wow, so maybe that makes sense.
Yeah. So pop quiz. I kind of already gave this one away, but we have a CI. So it's going to target the, exactly, circulatory system, and then a ZU, which is humanized. Yep, so 90 to 95% humanized. Perfect. So this is the Bevacizumab or Avastin, and it is approved for metastatic colon cancer, non-small cell lung cancer, glioblastoma, and metastatic kidney cancer. Sorry, I didn't catch up with my notes. Okay, so basically we talked about this one. How it works is it targets the circulatory system. So it's called a VEGF inhibitor, which is just vascular cell growth inhibitor. So it's basically stopping angiogenesis. So it's cutting off the blood supply to that tumor. So you're not getting any more circulatory system and essentially causing cell death without that. The big thing with this one you need to know, a lot of these will have a boxed warning. I'm not sure how familiar you are with that, but that's just the FDA's strongest warning that signifies that their drug carries significant risk of serious or event life-threatening adverse effects. It doesn't mean it's always going to happen when someone gets one, but it should just raise your awareness when you see a boxed warning that this has a pretty high incidence of happening, or it might happen. So for this one, it has a boxed warning against GI perforations, which is one of the main things we want to monitor for. And then really just think of blood. Think of bleeding, poor wound healing with this. We want to stop this medication 28 days before surgery and after, so you make sure that they get a complete wound healing. And really, that's all there is with this one. But I want to make note that with all of these, you're going to want to check the packet insert or check with the pharmacist if you have any questions. They're similar, but they're all different. So like, for instance, this one has the infusion reactions. The more I looked into this, it's really specific for each drug. You'll see infusion reactions on this. That can mean anything from redness at the infusion site to anaphylaxis to hypotension. It just depends. So in each person, sometimes it responds differently. So just check with each one of these. I'm not going to get into the details of that because I don't think you're going to walk out of here remembering which drug causes, redness, which one causes anaphylaxis. But just to make that a reminder that you're going to want to look that up as to what should you be watching for. And obviously, if the patient just starts acting different or doesn't feel well, that might be a red flag to look into it. So then we'll go into Cetuximab, which is an EGRF. So I kind of put this one by it because it's similar to the Avastin, where it targets the vascular system and growth factors, but this is more the epithelial cell growth factors. So as you can see up here, it's the TU, so tumor, and then it's chimerized, or chimeric, so it's about 35%, humanized. So really, this one, you're just going to want to watch for the skin reactions, which makes sense because that's our epithelial layer, right? So here you do have the Stevens-Johnson syndrome, or the toxic epidermal necrolysis, which I'm not sure if you've ever seen those, but they might be a word you heard about once. Everyone's really afraid of them. They're pretty scary, but they're not super common with this drug, but it is one thing you never want to re-challenge with these agents. If someone has gotten Stevens-Johnson syndrome or the TEN from this, you don't want to re-challenge it. If they just got an infusion reaction, you could try pre-medicating with diphenhydramine or something, which it recommends for the first dose, but not if there was any of these reactions. Anyone ever seen this in person? You have? Okay.
It's nasty. Yeah.
Yeah.
Don't forget it.
Don't you get the big blisters, the skin just moves
Yeah.
and gets all...
I kind of think of it, and this isn't a great term, but I think of it as almost like a leprosy, kind of looking like the skin's pulling away from the mucus layers. And I've never seen it in person, but I've seen pictures, and I don't want to see it in person. But, all right. So, and I'm going to cruise through some of these just because there's a lot of repetition. So if there's any questions, please stop me, and we'll just discuss them. So we have Certolizumab, which is Cimzia. And this is a different type of monoclonal antibody from the others, is it targets the TNF-alpha. So TNF-alpha is basically involved in systemic inflammation, and it has to do with the release of cytokines, and it makes up this acute reaction phase when you have inflammation. Which makes sense when you look at the approved for, which is Crohn's disease, arthritis, and this alkaloiding spondylolysis, which is like inflammation type response. So when you look at all these, it kind of makes sense that you want to target something that's creating this inflammation. And then it kind of makes sense too, because you're targeting this inflammation, which is part of your autoimmune response. So you're going to get more opportunistic infections from this medication. It does have a black box warning for risk of infection, TB, and malignancies in children, but this medication is not approved in children at this point for any of these agents. So it's just what's on there for a warning. But and then we'll move on. This one's going to look very similar because, again, it works in the exact same way of targeting that TNF-alpha. It has a few more indications that it's been approved for. But other than that, same thing, except for a little bit more infusion reactions. And we can use antihistamines, acetaminophen, corticosteroids to help manage these reactions. But again, the same box warnings for infections, TB, and HPV. A lot of these you're going to see that they want to do testing for TB and hepatitis B prior to treatment, just because these can be reactivated by a lot of these agents if they're latent in the system. So if you're ever concerned or you're not sure, maybe just check patient's profile, see if they've had a TB screening, see if they're negative, just in case, especially if they're a high-risk person. Okay, so here's one we might be a little more familiar with. They have commercials for this one now, the Prolia we see. Some of you might know people who are getting it as well. So Denosumab, Prolia, or Xgeva. Prolia is the one that's approved for osteoporosis. Xgeva is approved for the hypercalcemia and due to malignancy. So all it does is it inhibits the maturation of osteoclasts. So our osteoclasts, the ones that break down or build bones. You don't remember? I know I'm pulling back. So I always think of osteoblasts build bones. Osteoclasts break down. So we're stopping that breakdown of the bone, which makes sense that we might be getting some calcium deficiencies because of that, because that's where we get a lot of our calcium, and hence why we're treating the hypercalcemia for this. So one of the main things you'll see is signs of hypocalcemia. So we're not getting that breakdown. So one of the main things you'll want to see, if you're getting this, you see this, is make sure that they are supplementing with calcium and vitamin D during therapy, just to make sure. This is a pretty cool one. It's really changing how we're treating osteoporosis. Unfortunately, cost limiting in some areas, but compared to Fosamax, which is given daily or weekly, this is every 6 months. The side effects are a lot lower, and then just kind of the uncertainties of Fosamax with its up to 10-year half-life staying in the body, we don't have to worry about as much with this. So that's a little more common. Then we'll go to the Alemtuzumab, which is Compath. Not quite as common. It's only used for CLL, and it depletes leukemic cells by direct antibiotic lysis. So not really one we see as much, really more specific to that one type of that indication, and we're just going to be watching for opportunistic infections and hematologic toxicity. And then it has a long list of the box warnings here. So Nivolumab, or Opdivo, this is approved for melanoma and non-small cell lung cancer, along with renal cell cancer. And this one actually has a lot of trials going on. I think we have even a few here that are getting it through a trial. Maybe not. But yeah, okay. So this one, it might be one that you're going to start seeing a lot more indications in the future, just because they're finding out that it is able to affect a lot of things because it inhibits this programmed cell death, which doesn't really make sense because basically if you think about it, it's stopping these cells from dying. But a lot of these cells are cancer cells, so we want them to die. So it's kind of confusing, but it stops the cell death, which stimulates the T cell activation, which allows it to kind of hang out for a little bit longer and then allow the T cells to come back and fight it. So in a sense, it's kind of like holding it where it's at, so we're not getting the death and regrowth, death, regrowth, death, regrowth, and then allowing the T cells activation to come out and have a chance against those cells. So really we're looking at a few more toxicities here: pulmonary toxicity, nephrotoxicity, and then thyroid disorders, which is different than a lot of these other ones we've seen, and it has to do with the fact that it can cause adrenal insufficiency, which is a really long and kind of complicated process, but just know to watch for that, check a TSH maybe, and if you dose it with corticosteroids, sometimes that helps slows that down.
Is the source mouse on that, or what's the source on the
The mouse, it's human,
Oh, human, right?
so the U is, yep. Don't ask me what it's targeting, because we've tried to look this one up. I don't know exactly. I think it might be somewhere in that long list of indications, but just think it's targeting those cells, basically. So like I said, that foolproof method isn't foolproof on everyone, but okay. So Pembrolizumab, which is Keytruda, not going to talk too much about it because it's pretty much the same as Opdivo, just has a little bit different, slightly different indication, and then but pretty much exactly the same throughout. So, okay, and then Obinutuzumab, which is Gazyva. There's going to be a quiz at the end on how to pronounce it, so I hope you're paying attention. So this is similar, but it doesn't target programmed cell death. It just targets cell death. So when we were working over Hemo, we talked about this, and sorry I keep pointing you guys out, but you mentioned, you've had one person who got this and they had a really severe reaction, which makes sense because it's just targeting cell death in general. It's not very selective. And so the main thing you can see with this is the tumor lysis syndrome, and then a lot more infusion-related reactions, serious skin reactions, and hypertension. So I don't want to say it's not as safe, but just due to the mechanism, it's going to have more broad effects because it isn't very specific. And you don't see this one as much from what I've heard.
What kind of reaction did the patient have?
You were there?
He had some rigors and stuff, and then severe pain down in his legs and severe chest pain.
And this was during infusion?
And we were only doing like a trial dose, where we're trying to give him like 100 milligrams the first day, and then we would do the rest the second day. And so it was only, you're looking at it running like at 12 mils an hour.
They
So,
happen quickly? Would you say
Um,
leave them actually?
it was probably like 45 minutes in or something like that, 45 to 60 minutes in probably. So,
Yeah. So because of that, they do recommend slowly titrating the first infusion like you guys were doing, and then
it's titrated kind of like Rituxan.
okay. Yeah, and it is a similar mechanism as Rituxan. So I'm glad you brought that up. They're not exactly the same category, but they're very similar. And then you also have the pre-medications with this one that may or may not help. Okay. So here's a little bit different one. Let's see here. Omalizumab, which is Xolair. This one's kind of cool because it's kind of on the opposite spectrum. We're looking at asthma here, and not tumors and cancer or anything like that. So it works by inhibiting the inhibits the IgE binding, which limits the release of mediators in an allergic response. I am not an allergenist, so I'm not going to get into that cascade. But pretty much, when your body reacts to an allergen, it creates this whole cascade of inflammation, and this stops that. So it's pretty cool. It's only approved in adults, so older than 12. And there is the risk for anaphylaxis and hypersensitivity because you are messing with that allergic reaction cascade. And it should not be used for acute asthma exacerbation. And this one is of note because it does have the risk of anaphylaxis, but it's not first dose related. So they've shown it to happen with the first dose, but they've also shown it to happen in people who've been receiving a dose consistently for 2 years, and just to happen at that dose. So it's one you're going to want to observe the patient for at least 20 to 30 minutes after infusion, just to make sure this isn't that one time that it's going to happen. So kind of a different thing. And then they do have a skin test that they'll do to make sure people, kind of like TB, basically, and they'll watch it to make sure it doesn't balloon up so that they can get this. But yes.
Anything about safety during pregnancy with this?
On this one, I do not know. There is a lot of these are not contraindicated, which is kind of interesting because you would think they would. But a lot of them are category D. I'd have to look this one up specifically, but B. Okay, thank you. So category B, so it's safe in pregnancy. But yeah, it's kind of, as we get into the ones, especially for breast cancer, that you would think should not be used in pregnancy are still category D. So it's a lot of just decision at that time of who should get it. Okay, so Pertuzumab. So great segue. So HER2 overexpressing breast cancer. So it targets the HER2, and you get this severe infusion related. And then it does cause embryo-fetal death and birth defects, but it's not contraindicated. It's pregnancy category D. So just to use caution. And that's going to be very patient-specific and probably a long conversation to decide on using that. But that's pretty much it with that one. And it's very similar to Trastuzumab, Herceptin, which we might have heard about a little bit more. It's a little more common, but very similar. Same mechanism, and we're having those same box warnings. And then this one also has the possible alopecia, so the hair loss, and then nausea, vomiting, diarrhea. All right, so then Rituximab, which we talked about being similar to the Omalizumab, it stimulates cell death, and then it has the same box warning for Hep B, and then pre-medicating with a slow titration on the first infusion. So. All right, and then our last one is Vitolizumab, which is approved for Crohn's disease, which makes sense too, because it's approved for, it works by reducing chronic inflammation. And then you also get the hypersensitivity reactions. And for the main thing for this one, they just recommend that patients be brought up to date with immunizations, because we're kind of limiting that immunity, the defense mechanism, so we want to make sure that they're brought up to date. So that's it on all the monoclonal antibodies you might see here. That is not all the monoclonal antibodies you will see on the market. The list is about 4 or 5 pages long, so since you guys probably didn't want to listen to me for that long, maybe we'll just summarize it to what you might see. But as you can see, there's similarities, and what I really hope, I've gone through this about 10 times, and I still can't tell you everything about each one of these. But I hope you can kind of recognize and look, okay, this is going to be humanized, and this is targeting the immune system. So just to kind of be able to be familiar with these and what you might expect from them. And let's see. So just remember, biologic just means it's derived from a living organism. So anything that you see that's like insulin, blood products, vaccines, things that we see regularly, and maybe things we don't see regularly, but not really just this foreign concept of strange things we have to wear yellow suits for to touch. And then they're just very specific. Think of them as just a very targeted therapy to exactly what we're getting. And the purpose of this, which I think is kind of evident, maybe not, but the more specific we get therapy, the less side effects we're getting. So like I talked with some of you earlier, a lot of times they say with a drug you have the drug, and then this part of it goes for the response you want, this part of it causes side effects. So we're trying to remove this part that causes side effects. It's not perfect, we haven't got there yet, as you can see with the list of side effects for each of these, but that's kind of the theory of getting just right to the point of treatment. And then there's many more areas to come. And like I said, the guidelines are established for naming, so this shouldn't change. And that's why, as you notice as I go through, I don't go talk on brand very much. You should know brand, I should know brand, I'm not very good at it. But the generic tells you a whole lot more than the brand name. So that's where I would recommend just getting familiar with those generic names or kind of recognizing them. And then just for, if we have a little bit of time, I want to touch on this new class of monoclonal antibodies. It's called the PCSK9 inhibitors. And they're really cool because they're taking these things used for chemo in oncology, and now we're using them for hyperlipidemia, so high cholesterol. It's not widespread. It's not going to replace statin therapy, but they are another option to add on therapy. Right now, they're only approved for those who have maxed out statin therapy and who are looking for an adjunct therapy, and those with familiar hyperlipidemia. It's a very specific indication. They're looking at broadening this. There's no studies for head-to-head against statin. They're not for statin intolerance, unfortunately. So they don't recommend that, but they recommend, I don't know if you've heard of Xgeva or some of these other adjuncts, kind of replacing it in there, and they have shown really good reductions in these categories for adding it on to statin therapy. So not quite the answer we want for all those who can't take statins, but maybe possibly in the future. So just kind of put it on your radar, and just to show that there's probably going to be a whole bunch more indications for this type of medication coming down the pipeline. So here's my references, and I'll open it up to questions. And thank you.
So basically, we should just be prepared for all those chemo drugs, or what we thought were chemo drugs, being given on the floor as well. We should be prepared for it anyway.
Maybe, someday. I think right now, there's a whole lot of limiting factors, but I definitely think it's the area that people are trying to explore more. I think right now the main thing is the cost. And that's kind of why I brought, made sure Renee was here, because she knows more to the cost of these and how that works, but maybe potentially, someday.
Yes, right now the biggest factor is the cost, and when we're talking inpatient and limited by DRGs and our reimbursements from Medicare and Medicaid are so low, these are always going to be outpatient drugs until we can get them, probably drop down below the $50 dose. That's not going to happen.
Yeah, they're still around the thousands, and so it is cool. Yeah, go ahead.
Well, and one of the reasons we wanted Misty to talk about this is we're getting more of biologic medicines here, or what we thought were biologics, and then we had them the whole time. We just didn't even realize that. So there was some concerns amongst the nursing staff about which ones would cause a really bad effect in terms of really bad anaphylactic responses. So it was a good conversation. That's why we decided we probably should talk about it, because now that we know insulin is biologic, it kind of takes a little bit of the fear out of what's in the...
Yeah, and that's kind of the purpose. And then you can also, just look, like I said, at these namings. And like I said, it's not foolproof, but you can kind of, if you're concerned and you see like, oh, it has an O, so that is a mouse, so I should definitely see what could happen with it. Or just to kind of, I don't know, for me it makes them less scary, and it doesn't just sound like someone saying "mab" every 10 seconds. Because before this, I definitely just thought they made up some vowels and consonants and threw a mab on the end. But there's a reason. So, and they said there's a reason for even some of the first couple. It's like the guy who found it or stuff like that. So if you, I didn't want to get into that, but you guys can on your free time if you'd like. They're on Google. But yeah, any other questions?
I think I wanted to just underline something Misty said, which is these are targeted therapies, and the point of targeting a therapy is to decrease side effects and reactions. So while we should be aware of potential side effects and reactions, these are really actually a big step in the direction of safer drugs. So they're actually much more safe than many of the things we're used to getting on a daily basis, like warfarin, or you know what I mean, or high doses of aspirin, or I mean just a bunch of those kind of things. That doesn't mean we don't have to look at the patient and make sure it's not appropriate for this patient, or that once in a blue moon something will happen, because it will. But
All right. Well, thank you for giving up your lunchtime to come hang out. Hope you learned something.
Thank you. Thank you.